Hi, everyone. Thank you so much for joining us. We're going to go ahead and get started now that it's 11 a.m. Welcome. Thank you for joining us today for our webinar, Saving the Brain, a Community Hospital's Journey to World-Class Stroke Care. My name is Meredith Wentworth. I'm the Medical Marketing Manager for your host, EBSCO Health and Nursing Reference Center Plus, and I'll be moderating the session today. I'd like to start off by introducing our presenters, Diane Pravikov and Michelle Jackson and Teresa Tramo. Diane is our Vice President of Research and Lead Nurse Planner for EBSCO Health, as well as the Executive Editor for Nursing Reference Center Plus and Nursing Reference Center. Michelle joins us from GLENDALE Adventist Medical Center in Glendale, California, where she serves as the hospital's Clinical Program Stroke Coordinator. And last but not least, Teresa is a nurse practitioner working as part of the EBSCO Health team. Before we begin the presentation, I'd like to take a moment to go over a few housekeeping items. This presentation is scheduled for 1 hour, and we will set aside the last few minutes for questions. We'll have about 10 minutes set aside for you guys to ask any questions you might have on the presentation. Please feel free to submit your questions at any time during the presentation by entering them into the Q&A box on the bottom right-hand side of your screen. At the end of the presentation, we'll go through your questions and answer as many of them as we have time for. Should we not have sufficient time at the end of the session to answer all of the questions, we'll be sure to respond to you directly within a day or two so that you can get answers to those questions that you might have. It's important to note that this session is being recorded. The recording will be made into a video that will be available to all of you in the days to come. Please be advised that we've muted all audio lines to avoid feedback and interruption during the presentations, and we thank you in advance for keeping your line muted throughout the event. Again, please feel free to use the chat box on the bottom right of your screen to communicate with the presenters or myself regarding any questions that you might have. And without any further ado, I'd like to hand things over to Diane to get us started. And Diane, you should be all set.
Thank you, Meredith. As Meredith said, I'm Diane Pravikov, Executive Editor of Nursing Reference Center and Nursing Reference Center Plus, which are a couple of EBSCO's point-of-care nursing products. We are part of Sentinel Information Systems, which has been housed at Glendale Adventist Medical Center for over 50 years. Glendale Adventist is a 500-bed acute care facility in Glendale, California, a city of around 200,000 people. Sentinel stayed here even after becoming part of EBSCO in 2003, and because part of our publishing process involves nursing review, both the papers and the CEs we publish, I was fortunate to get to know Michelle Jackson, who was looking for CE modules for her nurses in her stroke unit, which she'll be talking about in a moment. Michelle is the epitome of what I hope will be the path for nurses everywhere. She began as an LVN, moved on to an associate degree, a bachelor's degree, a master's degree, and finally a doctor of nursing practice degree, and is a certified neuroscience RN. She started working at Glendale Adventist in 2007 as stroke coordinator in the Stroke Center and Neuroscience Institute with a specific assignment to bring us up to speed in that area. Within 6 months, she brought the hospital to earn Joint Commission accreditation as the first community hospital with primary stroke center designation in Los Angeles County. We are now the third hospital in Los Angeles County to be designated as a comprehensive stroke center, and she'll discuss the difference in those designations as part of her presentation today. Michelle is also an associate professor at West Coast University in Los Angeles. She works tirelessly to educate staff and the community, not only about prevention of stroke, but obtaining rapid treatment if one happens. And now she'll talk about saving the brain.
Thank you so much, Diane, for that wonderful introduction. So today, we are going to get started and looking at these objectives. Today, we will be discussing the different types of systems of care we currently have, which includes an acute stroke-ready hospital, a primary stroke center, and comprehensive stroke center. We will be discussing the differences between those systems of care. We will also examine the role of the stroke coordinator within these systems of care and how we can improve the care we deliver to our stroke patients. We will review the current state of our stroke care treatment, including IV fibrinolysis and mechanical thrombectomy. We will evaluate the strategies to decrease stroke treatment times and look at target stroke initiatives in order to speed up and increase the number of stroke patients we are treating. We will also review the lessons learned through our certification journey and some of our ways we have improved our stroke care in our community. So let's first get started with defining what is a stroke. So stroke is basically a lack of blood flow to the brain, causing damage to brain tissues that are caused either by a clot or a rupture of a blood vessel. There are three major stroke types. The incidence of an acute ischemic stroke, where brain damage is caused by a clot occluding the artery, is about 80 to 85%. About 15 to 20% of those are due to bleeds. 10% are due to an intracerebral hemorrhage, where we have bleeding into the brain due to sometimes caused by an uncontrolled hypertension, and 5% of those bleeds are due to subarachnoid hemorrhage, where we see bleeding around the brain, usually caused by a burst aneurysm. In today's lecture, we will be focusing more on acute ischemic stroke treatment, where the clot is occluding the artery. Here are some of the stroke statistics that we are dealing with now with regards to our stroke incidence. When I started in 2008 in developing the first community hospital primary stroke center in LA County, stroke was the third leading cause of death. And as more and more stroke centers are being developed and TPA use has steadily increased, we noticed that in 2011, stroke dropped to the fourth leading cause of death. Currently, in 2015, stroke has now dropped to be the fifth leading cause of death. I can tell you personally that there are very few diseases that have moved as drastically as stroke based on medications and programs to educate the public. It's still important to say that stroke is still the #1 cause of disability among adults in the United States, where every year 800,000 Americans suffer. It still kills over 128,000 people a year, and every 40 seconds, someone has a stroke. It's important to note and emphasize that 40% of those patients that suffer a stroke are due to a large vessel occlusion. And this will become more important as I've discussed the different types of stroke centers that we have. We all knew that faster treatments lead to better results, but it was not until Dr. Jeffrey Saver in 2006 in an article published in Stroke called Time is Brain, where it was quantified, time is brain is quantified. Dr. Saver was able to look at the brain cells lost every second, every minute, every hour. So for every minute you are having a stroke without treatment, about 1.9 million brain cells are lost. This means an accelerated aging of about 3 weeks. For every hour, 120 million brain cells are lost, accelerating aging for about 3.5 years. And on average, for every stroke, about 1.2 billion brain cells are lost, which accelerates aging over 36 years. So here is the current state of our stroke care. Depending on the time the patients arrive to our hospital, there are 3 ways we can treat our acute ischemic stroke patients. If the patient arrives outside of the treatment window, we can offer medical management, supportive care, monitoring, and allow for secondary stroke prevention. If a patient arrives within the treatment window of up to 4.5 hours, intravenous fibrinolysis, or TPA, tissue plasminogen activator, also called Altiplase or Activase, can be used. Additionally, we can now bridge therapy using an endovascular clot removal for those patients that arrive within 6 hours of stroke symptoms. These procedures, using a stent retrieval device, can be done in the cath lab. So despite all the endovascular therapy, IV TPA tissue plasminogen activator remains the gold standard. So TPA is a systemic clot buster approved by the FDA for the only treatment for an acute ischemic stroke since 1996. However, despite this wonderful treatment, we're only able to see reperfusion on our stroke patients in about 13 to 50% of those patients that suffer a large vessel occlusion. So what is a large vessel occlusion? We are quite familiar now with our cardiac patients and the terminology for STEMI, ST elevation myocardial infarction for emergent cardiac needs. In neuro, we have what's called an ELVO, that's described as an emergent large vessel occlusion. Over 40% of ischemic strokes are due to these large vessel occlusion. This means that there are blockages in the internal carotid artery, the middle cerebral artery, and the vertebral or the basilar artery. Clots in these vessels have an increased mortality associated with this. For example, with the ICA, there's over 50% mortality rate, MCA about 27%, and unfortunately with basilar artery occlusions, over 89 to 90% mortality rate. So these large vessel occlusions have been major concerns. And fortunately, we have additional technological advances that we can use for those patients who are suffering with ELVO, or emergent large vessel occlusion. We have the Stent retriever technology, and these have improved revascularization, opening up those vessels, and improved patient outcomes versus old technology, and this has been proven in multiple randomized clinical trials. Large vessel occlusions can only really be treated by using a Stent retriever that the American Heart Association and the American Stroke Association updated its guidelines and added the use of these Stent retrievers in conjunction with TPA therapy as a first-line treatment in some of our patients with an acute ischemic stroke. These Stent retrievers that we have available now are called either the Solitaire device, which is made by Medtronic, or the Trevo, made by Stryker. However, if the patient arrives in the hospital within a TPA treatment time window, TPA should and still would be administered. However, the patient will be considered for an endovascular procedure depending on the CT angiography results and patient signs and symptoms after the TPA has been administered. So here are some of the criteria for patients who can be evaluated for an endovascular procedure. Number one, patients should have a pre-stroke modified ranking score between 0 to 1. A modified ranking score is a 7-point scale that measures the degree of disability or dependence of patients with activities of daily living, where 0 meaning no symptoms and 6 meaning either severe disability or death. Other criteria include acute ischemic stroke patients receiving TPA within 4.5 hours of onset, occlusion of a large vessel, either the internal carotid, the middle cerebral artery, or the basilar artery, an age of 18 years or over, a patient who has a National Institutes of Health stroke scale score of 6 or greater, an Alberta Stroke Program early computed tomography score, or an aspect score of 6 or greater in the CT scan. A normal CT scan receives an aspect score of 10. The lower the number, the more ischemia or damage we are seeing in the CT scan. And also for those patients whose treatment can be initiated within 6 hours of stroke symptom onset. Here is the 5 landmark studies that prove that Stent retriever devices, in 2015, a meta-analysis of these 5 randomized controlled trials, ESCAPE, REVISCAT, Mr. Clean, Extend IA, and SWIFT Prime, found that patients receiving these stent retrievers had no difference in the rates of symptomatic ICH or intracerebral hemorrhage compared to those receiving standard treatment alone, which is TPA. The stent retriever group into these studies also showed that there was a trend to decreasing the 90-day mortality rates on acute ischemic stroke patients, and these were the 5 landmark studies, 5 landmark trials that proved that stent retriever devices were just as superior to TPA. So in just a review of the current state of stroke care, in the 1990s and before that, stroke was really just treated with supportive care, medical management. However, in 1996, because of the FDA approval for TPA for treatment of acute ischemic stroke was brought into place, treatment has really changed for stroke patients. In 2004, we started seeing the first primary stroke center in the United States. In 2009, TPA was approved for an extended period of time treating patients up to the 4.5-hour window. And in 2012, we started seeing the first comprehensive stroke centers. And in 2015, based on those 5 trials, we had solid data to support that mechanical endovascular reperfusion therapy or thrombectomy was another first-line treatment for stroke patients. So what we have learned is that recognition and early intervention becomes a cornerstone of our stroke treatment. We are very focused on time is brain. How can we have these patients, these stroke patients receive these timely care by having an organized and systematized care? This will improve our patient care for stroke patients. So stroke systems of care, here are the different types of capabilities of our hospital. I want to begin by introducing these 3 types of stroke centers in our country today that began as an American Stroke Association task force in developing the stroke systems of care. So these stroke systems of care integrate regional stroke facilities that include the acute stroke-ready hospitals, the ASRHs, which have telemedicine and teleradiology capability, the primary stroke centers, and comprehensive stroke centers. All these stroke systems of care include stroke prevention, community stroke education, a strong EMS support and partnership, effective acute stroke care, rehabilitation, and quality performance review of the stroke care delivered to our patients. All these 3 types of stroke centers must have the capacity and commitment to deliver acute stroke care in the emergency departments. Majority of patients are now being transported by the EMS to these stroke centers, all of which optimizes a stroke patient's chance to receiving appropriate therapy to decrease morbidity and mortality for stroke patients. So I'd like to start with describing the acute stroke-ready hospitals. These hospitals have made a commitment to effectively and efficiently evaluate, diagnose, and treat the emergent stroke patients. The main difference between an acute stroke-ready hospital versus a primary stroke center is that acute stroke-ready hospitals really do not have a fully organized inpatient stroke systems of care. However, they do have the following to immediately treat a stroke patient based on the model that is similar to a hub-and-spoke model as seen in the picture on the slide. Acute stroke-ready hospitals have written emergency stroke protocols. They have a transfer agreement with primary stroke centers and comprehensive stroke centers. They do have a director of stroke care that oversees hospital stroke policies and procedures. This person can be either a clinical staff member or someone designated by the hospital administrator. They must maintain a stroke patient log. They must be able to administer intravenous TPA, therefore have the ability to perform 24/7 CT imaging and emergent lab testings, and they must have access to telemedicine and teleradiology. Acute stroke-ready hospitals have the potential to extend the reach of a stroke system of care, most especially in underserved regions, so smaller hospitals. Primary stroke center, on the other hand, was established in 2000, and primary stroke certification started in 2004 by the Joint Commission. No matter who the certifying agency is, the Joint Commission, the DNV, or the State Health Department, it is mandatory for all primary stroke centers to closely track their performance on key quality stroke measures. The goal of primary stroke centers are to deliver effective and efficient stroke care. Clinical trials have proven that patients with strokes that go to primary stroke centers have improved clinical outcomes and increased the rates of IV TPA administration. Other benefits of a primary stroke center in stroke care include shortening that door-to-physician contact time or evaluation. It decreases door-to-CT time completion. It decreases the door-to-TPA time, which is the administration of stroke treatment. And more importantly, it increases TPA usage. And finally, the comprehensive stroke centers. The scientific statement delineated the set metrics and related data that comprehensive stroke center should track to ensure optimal stroke outcomes and adherence to current recommendations. In a CSC, they should be able to offer 24 hours a day and 7 days a week state-of-the-art care. As I mentioned earlier, accreditation for a comprehensive stroke center began in 2012. Critical and essential elements of being a comprehensive stroke center include having a neurocritical care unit that is neurologically focused in improving clinical outcomes that include reduction in complications and reduced days of hospitalization. Neurocritical care units should be able to care for patients with severe stroke deficits, large volume infarcts, with the potential for significant cerebral edema, significant comorbidities, blood pressure that is difficult to control, post-TPA patients, and patients who have received intra-arterial interventions. In order to become a successful comprehensive stroke center, there are 26 metrics that are the distinguishing features of a comprehensive stroke center. I'll briefly go over the different metrics involved. In metric 1 to 11, the focus in the management of the stroke patients. It includes the use of NIH stroke scales to document the disability or the stroke as a stroke assessment. It monitors TPA administration up to 4.5-hour window, monitoring of door-to-needle time and the speed we treat our patients, the use of CT or CT angiography on patients whose last known well time was less than 6 hours, and that endovascular procedure was considered, the time endovascular procedure was started, the number of TPA patients or endovascular patients that develop a bleed within 36 hours need to be monitored. In metrics 12, 19, and 20, those focus mostly on the patients with an intracerebral hemorrhage. Measurements of those include documentation of the Hunt and Hess score or the ICH score or the Spetzler-Martin score for AVMs. Also monitoring intracerebral hemorrhage patients with treatment of reversal agents are included in these metrics. Metrics 13 to 18 mostly deal with our management of the subarachnoid hemorrhage patients. So we look at the median start time for ruptured aneurysm patients and how fast we clip or coil these aneurysms, and the number of patients who develop complications. Metric 21 is specifically about the stroke systems of care and how we track inter-facility transfer time in receiving patients from primary stroke centers, for example, or even acute stroke-ready hospitals. Metric 22 is focused on our intensive care unit in our stroke units. We track the number of stroke patients that go to specialized stroke units, our neuro-intensive care unit and our neurotelemetry unit. Metrics 23 and 24 all focus on outcomes and complications. So we keep track on the number of death or complications, post-cerebral angiography, EBD, and patients that develop any type of infection or ventriculitis. Metric 25 involves the involvement of rehabilitation with our stroke patients, and metric 26 involves research and the number of patients we enrolled in stroke-specific clinical research trials or studies. So these are our stroke systems of care. We've already shown you how we have done this through the effective acute stroke care, but it also includes and encompasses a whole series of systems such as stroke prevention, community stroke education, optimal use of EMS, developing that relationship with our EMS. We've talked about stroke care systems and also the rehabilitation of our stroke patients. So I want to talk to you about our journey in becoming a comprehensive stroke center. In the left, we just recently celebrated our 110-year birthday. On the left, that was our original hospital, was known as the GLENDALE Sanitarium, to our hospital now, and that's a view of our emergency room and our neuro ICU. So a successful comprehensive stroke program or stroke system of care really involves a good stroke coordinator who can manage the different parts of the puzzle. So these are, I've listed some of the things that a stroke coordinator can do. Different hospitals have different roles of stroke coordinators. Some hospitals have one, just a dedicated stroke coordinator. Some hospitals have a stroke coordinator who also deals with sepsis or chest pain, and there are also bigger hospitals, university hospitals, that have more than one stroke coordinator. But I just wanted to list down here some of the things that a stroke coordinator does. So primarily they coordinate hospital stroke protocols, policies, and procedures, ensuring that clinical practice guidelines are current and followed by everybody from the moment the patient walks into the hospital to discharge and follow up afterwards. The stroke coordinator responds to stroke codes or stroke alerts, emergency, when a patient's coming into the emergency department. The stroke coordinator rounds on stroke patients, making sure they communicate, educate with our stroke patients. We also facilitate inter-facility stroke transfers, dealing with smaller hospitals, non-stroke facilities, acute stroke-ready hospitals, and even other primary stroke centers. We ensure the certification of a program to ensure that we have the appropriate for certification for the Joint Commission or DNV, or even in some instances the Department of Health. Following up on core measures and key quality indicator for every patient that is admitted to the hospital. We do data abstraction and reporting. We utilize here at GLENDALE, Get With the Guidelines. We report and disseminate data to every department that we deal with. We report back data back to the emergency department personnel, doctors, nurses, the EMS, to our CT, laboratory, every department that's involved with the care of that stroke patient. We need to report back and disseminate all of those data that we've abstracted so we can continue to improve our processes. Also doing the hospital-wide education and competencies for all the nurses and physicians that work in the ED, our neuro ICU, our neurotelemetry, including hospital-wide education. Outreach and lectures to our community is also a big part of the job. Also education and relationship building with our EMS, and also program growth and marketing. Now, a stroke coordinator cannot do all this without a successful stroke team. So a stroke coordinator is responsible for bringing the team together, all in the care of that stroke patient who comes into our hospital. So we need to implement effective performance improvement to reduce in-hospital time delay of TPA administration. In order to be successful, input and collaboration includes many, many clinicians and that includes our EMS, our neurologists, our emergency medicine physicians, our radiologists, our nurses, our CT technologists, our lab technologists, our pharmacists, our registration associates, and most importantly, having that strong leadership support. A well-organized stroke team approach is essential for the implementation of timely acute stroke care, which equates to excellent stroke delivery to our patients. So in order to have a very successful stroke team, we must have nurses that are well educated. Here's an example of our stroke workshop that we offer to our nurses at least 3 to 4 times a year. This is our medical director who is giving one of our courses. This is an 8-hour education for our nurses in our ED departments, our neuro ICU, and our neurotelemetry units. In addition, we also do on-the-spot education in services in the units monthly. We also utilize health stream modules and also the Nursing Resource Center as part of our education. So it's really important that our nurses are engaged. So we ensure that on a yearly basis, we send our nurses to stroke conferences. Here's an example of 10 of our nurses that we sent to, this was in Los Angeles for the International Stroke Conference. Having staff that's engaged, having staff that is knowledgeable, really improves the care we give our patients, with our stroke patients. So like I said earlier, stroke centers need to ensure that every member or every person in the hospital, whether they're working in security, in transport, our volunteers, our environmental services, our kitchen staff, everyone, every person that works in this hospital should be familiar with stroke. They should be able to identify if there was an emergency, somebody was in a hallway, somebody was in the cafeteria, to be able to identify quickly if a patient was having a stroke and be able to activate the stroke system, stroke alerts, stroke codes within the hospital. Okay. Then I want to talk about the Target Stroke. This initiative was started in 2010. Target Stroke is a national quality improvement campaign of the American Heart Association, American Stroke Association, to improve the outcomes for ischemic stroke patients by helping hospitals achieve door-to-needle time of 60 minutes or less. Because of this Target Stroke initiative, because we knew that time is brain, and the faster we treated our patients, the better our outcomes will be. We knew that a big part of our partnership in improving our door times is really reaching out to our EMS personnel, EMS representative. So we started a pre-hospital education. So at least twice a year, we offer this to our EMS, where we have lectures. We offer courses on how to identify a stroke patient quickly so that the stroke patients will be delivered to the appropriate centers, stroke centers. So that initiative was successful. We were able to provide treatment to our stroke patients quickly and rapidly. However, 60 minutes just wasn't enough. That in 2014, a phase 2 was introduced by the American Stroke Association to continue to challenge us, because we know that we can do 60 minutes better. I bet, because time is brain, treating a patient even faster than 60 minutes should be better. So with Target Stroke Phase 2, the goal was to treat patients, more patients, up to the 45-minute window, and this was really a challenge for us. So in Target Stroke Phase 2, the goal was to achieve door-to-needle time of 60 minutes in 75% or more of our patients, and half of those being treated within the 45-minute time mark. So we knew that we needed to do more outreach, and we needed to work on our protocols. This is just one example of what we did to reach out to the EMS, where we set up booths right outside our emergency department so that we can reach out to our EMS personnel. We actually gave them a 360, which is a patient feedback of the patients that they brought to our hospital and how fast we delivered certain treatments, how fast our door to CT was, our door to treatment was, and how fast we were able to bring the patient up to the cath lab. On the left, the picture on the left, we actually showed them the stent retriever devices. The paramedics were able to touch and feel and see the improvement and see what we really do for our stroke patients. So this is one of our successful programs. We do this about twice a year, where we're out there educating and campaigning on how important it is for stroke patients to be brought to stroke centers like ours. Besides working with EMS, we also noted that to improve our stroke times, in order for us to deliver stroke treatment as fast as we can, we knew we had to do something else. So a couple of things that we started was having a EMS pre-notification. So while the patient is out in the field and the EMS is communicating with us as a base station, we already knew what the estimated time of arrival is for our patients, and we activated overhead in our pagers through the entire stroke team that a patient was coming into our facility. So within that period of time, whether it's 3 minutes to 5 minutes of arrival, we were already there, ready to greet the patient before they even arrived. So pre-notification was very important. It really improved our stroke treatment times with faster imaging and faster door-to-needle times and faster TPA treatment. Another thing that we initiated was the door-to-CT protocol. So when the EMS brings the patients in to our emergency room, the patients did not have to be bedded immediately. The EMS went directly straight into our CT scanner. And we found that we improved our times to CT completion from what used to be an average of about 25 to even 30 minutes at times, now cutting it down to less than 10 minutes, with our best time being less than 5 minutes. So it improved our door-to-CT time. It also improved our relationship with the EMS. While the EMS is up there in the CT, I took that opportunity to teach them and show them about the results that they're seeing on the screen. So we had some challenges throughout all this in reduction of our door-to-needle time. We saw that there was some variation in clinical practice. There was a lot of staff turnover, and that's normal for every facility, so it's a lot more of education and continuing education for staff. But more importantly was that our community was unable to recognize the symptoms of stroke, and they're not activating EMS. They're not calling 911. So what happens was there was a delay in arrival to our hospital, and therefore we were not able to provide the appropriate treatment for them. Most of the times they would come over 6 hours, 12 hours, and sometimes over 24 hours from the stroke symptom onset. So what we did for those were we had an aggressive community outreach. We made sure that we provided a pre-test and a post-test. We emphasized the importance of activating EMS by calling 911. We told them about the treatment for stroke, including TPA and endovascular therapies. We instructed them on the signs and symptoms of stroke using the FAST mnemonic. Taught them about risk factors for stroke and what is a stroke. Those are all part of our educational outreach in our community. We also did stroke health screenings where we set up a 2-day event where we provided free services that included a physician consult. We provided free carotid ultrasound screening, blood pressure screening, evaluating patients for stroke risk assessment, even doing cholesterol screening, providing stroke education, measuring BMI as part of these health screening that we were able to do for our community. We also had, during Stroke Month, had these events that were fun. We found ways for people to engage and remember these stroke symptoms and to activate EMS, calling 911. We had games. We involved the community. So we found that anything fun, and patients were engaged and ready to learn, and we didn't make it like it's so grim. Oh, you're going to have a stroke. You're going to die if you didn't call. No, we made it fun. We made it engaged. Our community loved it. So these are some of the fun things that we were able to do with our community. This is just an example of how we involved our city of Glendale. For many years, we had our 5K run where we raised stroke awareness. A lot of these funds that were raised directly went back to our community in providing stroke education. Every year when we would have this, we'd have over 1,500 participants. So we found ways to really engage our community in learning about stroke and understanding the pathophysiology of stroke and the importance of calling 911, including the different types of treatments that we have available now. So with some of those funds that we raised, we were able to purchase one of these stroke education mobile unit. So it's a touch screen mobile unit. We've loaded up about 10 to 15 different kinds of videos and educational programming within this mobile unit, and we take this over to the Galleria, to the mall, to the high schools, to the daycare centers, to any events that we have. So this is just one of those things that we've used the funds from our stroke awareness and going back to our community and continuing that outreach and that education. Here's an example of how we partnered with our local television community. So this was a time when our neurologist, for a span of 6 hours, were manning the phones. It was an 800 line that we set up, and our neurologists for 6 hours straight were just picking up the phone, and the community can call in, and the neurologists were able to answer all questions that anybody in the community would have about stroke. And it's a direct line to a neurologist, and this is just one way that, you can reach out to the community, because it's one thing to have treatment available, and another if people don't even know about it, and not even knowing that there's a treatment window and how critical that stroke treatment is. So I want to share some of our lessons learned and how we improve the timeliness in the delivery of this life-saving stroke treatment. So first, advanced hospital notification by EMS is key. Having the team there waiting before even the patient arrives in our door is key. Having a rapid triage protocol and early stroke team notification. Having a single call activation system. So one call to the operator activates everybody in the stroke team's pagers. Implementing that door-to-CT protocol, where when the EMS comes into our door, we don't find them a bed where they have to bed the patient in the emergency department, but instead going straight to that CAT scan and really determining what we're dealing with. And access to in-house stroke expertise 24/7 was key. Having a rapid brain imaging protocol. Having our emergency department registered nurses competent in mixing TPA really cut our time. That's very precious time, even if it's just that 10 minutes. 10 minutes is equivalent to 20 million brain cells, so any way we can cut and make the process lean is really important to delivering that fast treatment time. A team-based approach to stroke care is important. Everybody needs to be engaged when focusing on the treatment for a stroke patient. Every stroke patient comes into our hospital with different set of symptoms, so it's really important that we identify those stroke patients quickly and efficiently. We also ensure that our TPA is stored in our emergency department. We don't have to go down to the pharmacy to pick up TPA. It's stored in our Omnicells in the ED. Having a regular feedback on door-to-needle times to our team, to our nurses, even to our emergency medical personnel, or EMS, knowing that they were able to identify that patient and look how fast we were able to give treatment and how quickly the patient recovered and back normal without any stroke deficits. Those are things that they want to hear. Some of the positive feedback, and even on some opportunities or challenges on how we can improve our care. Reward and recognition of staff. So we celebrate these quick turnaround times. We want to repeat these successes. Having a champion in the emergency department and stroke unit is key. The stroke coordinator cannot be there 24/7. So having that champion that you assign in the emergency department, in the neuro ICU, in the neurostroke units, that could really help you out in, identifying patients with stroke, taking charge, leading the team, is very, very effective. I cannot tell you how important a strong leadership support and participation is to all of our success. Without our leaders supporting us, encouraging us, we really could not have this successful stroke center that we have now. And most importantly, celebrate every step of the success, every award, every achievement, every record-breaking door-to-needle time should be celebrated to encourage people, involving people. Here in this picture, I've got everybody from our social worker, our dietitian, our physical therapist, our occupational therapist. They are all part of the team. And so this is how we do it, and this is how we've really have a successful stroke center here at Glendale Adventist. So thank you so much.
Thank you so much, Michelle. That was a wonderful presentation. At this point, I'm going to try to turn it over to Teresa, who is our next presenter, who's going to give just a little bit of information on EBSCO Health. And Teresa, you should have the ball now. Are you able to speak on audio? All right. It looks like we're having a little bit of trouble with our audio connection for our next speaker. So at this point, we will open up the Q&A section if anyone wants to send along any questions that they might have for Michelle on her presentation. You can feel free to do so right now through the Q&A box at the bottom right of your screen. And let's see if we can get this started. I do have one question here. So Michelle, what are the core measures that need to be followed on stroke patients?
Good question. So on all our stroke patients that arrive into our emergency department, the stroke measures that need to be followed obviously is that when they are coming in, that we evaluate every stroke patient for thrombolytic therapy. Additionally, we need to make sure that our stroke patients receive, especially our acute ischemic stroke patients, that they receive antiplatelet therapy within the 48 hours of arrival. Additionally, we make sure that all our acute ischemic stroke patients are placed on statin agents. We ensure that they do VTE prophylaxis on our stroke patients. Anybody with atrial fibrillation need to have anticoagulants on board. They also need to have rehab evaluation with either or all, with physical therapy, occupational therapy, and speech therapy. And they need to receive proper stroke education, which includes knowing the risk factors, knowing signs and symptoms of stroke, knowing signs and symptoms of stroke, knowing when to activate EMS and 911, knowing their medications and their follow-up with their physicians. Those are key elements that we have to ensure our stroke patients have on every patient that arrives to our hospitals. Those are called the core measures on every stroke patient.
Great. Let's see here. It looks like our next question says, does the ED call overhead as code stroke within the department so the staff knows and additional staff can help speed things along?
Oh, absolutely. So our ED it's just one call to the operator, or we dial a number that we identify for code strokes, and it's not only overhead paged in the entire hospital, but also goes through the whole entire stroke team by one call alone. So a single page system is what we utilize. And we found that to be effective because everybody in the team knows that there's either a stroke patient in the emergency department or a stroke patient is en route to the emergency department.
Great.
So that one call system is key. And it activates all our pagers and overhead paged.
Thank you, Michelle. Let's see. The next question we have is, do you teach EMS to bypass acute stroke-ready hospitals that are able to administer RTPA and transport to a comprehensive stroke center?
So currently in Los Angeles County, we do not have that yet. However, that is soon to come along, and identification of what I talked about earlier on the large vessel occlusion is the key to identifying which patients should be going to either a primary stroke center or a comprehensive stroke center. We are currently now teaching our EMS on identifying, on certain assessments to identify patients who may have large vessel occlusion. Because currently in Los Angeles County, there are only 3 comprehensive stroke centers, we really still cannot bypass primary stroke centers. But hopefully by the end of the year 2016 or early 2017, as we are hoping, as more comprehensive stroke centers are available in LA County, we will be able to do something like that by bypassing. And I know some communities or some states in the East Coast are already doing that. So we're about 6 months away to 8 months away from having that happen. So it's very, very close.
Perfect. Thank you, Michelle. So it looks like we've fixed the audio connection here. So I am going to pass the ball to Teresa. Teresa, you should be all set. And if you just want to unmute yourself, you should be good to go.
Good morning. Thank you, everybody, for your patience and as we work out the technical difficulties and for taking time out of your extremely hectic schedules to join us today. At EBSCO Health, one of our missions is to support the evidence-based medicine and to improve your patient outcomes by providing healthcare professionals with the most current and useful information available. And hopefully today's webinar helps support that mission for us. For those of you unfamiliar with Nursing Reference Center Plus, I wanted to spend just a few moments to briefly mention some of the benefits, especially around the topic of stroke, and the importance of developing hospital-wide protocols that we referenced quite often in this webinar, and educating the community in the importance and timely recognition of stroke and its symptoms. Nursing Reference Center Plus is a web-based reference center committed to educating nurses through evidence-based medicine and providing best nursing practices. As part of that effort, Nursing Reference Center Plus focuses on ensuring that staff nurses, nurse educators, recent grads, and nursing students have a very quick and easy access to the most current information to provide the best care possible for your patients. Some examples of the content within Nursing Reference Center Plus that can assist your stroke coordinator and anyone on your stroke team, even the EMS, is care plans. Your patient outcomes will be mentioned in that. Some core measure topics, as you know, stroke quality measures are tracked and followed and reported. Disease topics, leadership and management topics, regulatory topics, medication references, skills with competency checklist. We also provide images and videos. And one important issue is to be able to provide patient education in both English and Spanish. And all of you on the phone know that when you're working with patients and getting ready to discharge them, that's very important that they can have something in their hand to understand the process and what's happened to them that they can refer back to once they're home. We all know that continuing education plays such an instrumental role in providing both quality care and ultimately improving patient outcomes for all of our institutions. So we at EBSCO wanted to share with you some of the most popular CINAHL continuing education modules based on usage. And what was interesting when I looked at this list is that 7 out of the top 10 all were stroke related. They were topics like stroke and cholesterol, ischemic stroke, hemorrhagic stroke, stroke and dementia, DVT, stroke complications with DVT, stroke in women. So this is a topic that we as healthcare providers are facing, and it's something that we need to address. And at EBSCO, we're committed to help supporting that. So in summary, we all know that stroke quality metrics play an increasingly important role in both quality improvement and our policies within our hospitals related to provider reimbursement, accreditation, and public reporting. Nursing Reference Center Plus can help sustain stroke policy and procedures and the relationships between compliance with stroke quality metrics, patient-centered outcomes, public reporting of stroke metrics, and most of all, quality improvement within your organization and the quality of care that we provide our patients. And with that, the outcomes of our patients will be on the upswing and be positive. So again, I want to thank you for your time, and I will turn it back over to Meredith and Diane.
Thank you so much, Teresa. That was wonderful. I'm going to continue on with the Q&A right now. We do have a couple more questions, and we have a few more minutes if anyone else wants to submit anything else for the Q&A. But it looks like our next question is, how do you document within your EHR during a time of code stroke and dedicated document section?
Okay, so for us, our code stroke, and I don't understand the question, but I can answer it in, if it is about your physicians calling a code stroke. So in our hospital, when a physician calls a code stroke, we pull that information either from the physician notes and also from the stroke order sets that the physician has ordered. During a code stroke, we have the physician ordered our quick orders for all our CT and labs, so they can just put in an order very quickly and initiate all of those emergent diagnostics that we need for a stroke patient. With regards to nursing, we have a form where we keep track of every step of the patient's time, and that we do in a separate piece of paper, and we report that out monthly to our staff, and that is what we use for feedback. But with regard to just having that code stroke available in the electronic health record, those are just some of the ways that we could identify that this patient was a code stroke and a code stroke was through a physician note, a physician order, and then we have that stroke code audit sheet that we fill up at every stroke code event. For me, because I track every stroke code, I've involved the hospital operator who keeps a log for me on every stroke call patient, and I'm able to pull that data and then be able to fill in all of my tracking metrics on that stroke patient. How fast did my emergency department physician see the patient? How fast did that patient complete the CT scan? How fast was the CT reported? How fast was the labs drawn? How fast were the labs reported, for example? So all of those are kind of the comprehensive way of how we document our stroke codes.
Great, thank you. And the next question here says, what are some of the best ways in getting the attending physicians involved with our stroke patients and being more consistent with core measures such as statins, antiplatelets, et cetera?
Excellent question. So engagement, education, and also for us here at Glendale Adventist, every stroke patient that gets admitted, we always have our neurologists on board who are pretty much the ones managing the case. So we make sure that our neurologists are very well educated. We have our 5 doctors in our stroke call panel, and they are well tuned to the core measures, so we do not miss a thing in that core measure, and that we are on time with our statin agents, with our antiplatelets, that all our patients with AFib have anticoagulants on board. It's very rarely that a patient would be admitted, and I don't think it really happens to us, because once we've identified the stroke patient, our nurses are so good and quick to do a couple of things. Number 1 is to get that primary doctor to order a neurologist immediately, and number 2 is to get that patient out of that non-stroke unit over to a stroke-specific unit, which is our neurotelemetry unit or our neuro-ICU. But it is really, really important that we ensure that we engage, we educate our doctors. So we find every opportunity where we can educate our physicians through a CME event, for example, really engaging them during stroke months. We have residents that come in on certain times of the year. We ensure that we educate those residents as well with regards to our core measures, our key quality metrics. So lots of education and conversations with our physicians to get them really engaged.
All right, thank you. So it looks like we've hit the 12 o'clock mark, and so at this point I'm going to wrap up. If you do have any other questions that you think of after the session and want to send them along for Michelle, please feel free to do so. You can contact me directly. My email address is mwentworth@ebsco.com, and I'll be happy to sort of be the middleman and get you in touch with Michelle.